Good evening once again, everybody. I welcome you all to this monthly ISCCP webinar. And today we have a very, very interesting theme, which is on treatment of cervical precancerous lesions. And we have the convener, Dr. Upasana, today, and Dr. Helen so they are going to steer the meeting. And before we start the interesting meeting, I would now like to invite Dr. Shweta Bolani. She is the Vice President of ISCCP to give the welcome address. Over to you, Dr. Shweta.
Hello, good evening. I'm here to welcome you all on behalf of Dr. Aruna Nigam, who's our president. And I'm so happy and glad to have all the Northeastern faculty today. And we really want to spread our roots to the Northeastern states, which is the ISCCP Northeastern state coming up. This time we'll be having our annual conference in Chennai on 28th and 29th of March. I would really want the participation from these states, and I would welcome Dr. Helen and congratulate her to carry on this flag of ISCCP in the northeastern states. Dr. President of our past president has done such wonderful work, and now the target is all on the northeastern states. I welcome you all. I'm so glad that Dr. Helen has made so many panelists from these states, and we are happy to have you. Welcome you all on board. Thank you very much.
So thank you, Dr. Shweta. And again, welcome to all the faculty and the delegates. And without wasting any time, now I hand over the session to Dr. Helen and Dr. Upasana. Over to you both. Dr. Helen, please.
Thank you so much, Dr. Vindhya. Thank you, Dr. Shweta Bolani. With this, I think without much ado, I'll invite our chairpersons, Dr. Pankaj Deka and Dr. T.H. Netajani. Dr. Pankaj Deka is a gynecologic oncologist from Assam, and Dr. Netajani is a professor in Jennings, Imphal. So, ma'am, sir, kindly invite the speaker for the session.
Yeah, good evening, everyone. And first of all, I'd like to thank Dr. Helen for organizing this meeting and organizing so many of the people from Northeast. And today's discussion, the very important topic about the management of precancerous lesion. For that, I like to invite our speaker, Leela Degumurti ma'am. She is a associate professor in Homi Bhabha Cancer Research Center, Delhi. Please, ma'am, the dais is yours.
Yeah, thank you very much for your kind introduction. But I'm no longer associated with Homi Bhabha Cancer Hospital. We have moved to Hyderabad.
Okay.
So anyway, I'll be showing that in my one of the introductory slides. It's okay. Yeah. So let me share my presentation first.
So meanwhile, while ma'am is sharing the presentation, I would like to tell that ma'am was the previous president of ISCCP, and she was instrumental in starting the colposcopy course and the training program of ISCCP. And ISCCP grew leaps and bounds under her umbrella. So we really owe a lot to you, ma'am. So welcome.
Yeah, thank you. It's the effort of everybody, and I'm very happy that it's being carried forward with a very dynamic and enthusiastic team. So at the outset, I thank the organizers, basically the ISCCP team, as well as Dr. Helen Kanye for inviting me to talk on this management of precancerous lesions of cervix. Yeah. I hope it moves. Yeah. So what we understand about cervical pre-cancer, it's an eminently preventable disease. Cervical cancer is an eminently preventable disease. We are all trying our best to look forward for eliminating the cervical cancer, especially after the announce of the global declaration of WHO targets. So we know that cervical cancer actually starts as a precancerous condition that can be detected with reasonably accurate and feasible screening tests. So most of us are familiar with the screening tests, BIA, pap smear, and HPV tests. Then precancerous lesions are successfully treated using relatively simple technologies. Again, we are all aware of the various ablative and excisional methods for treating cervical precancer. Well-organized screening programs can achieve high screening coverage of the target population. So that's what we are all aiming for. And it's not just doing the screening tests alone. High compliance to treatment and follow-up of these women who are diagnosed with the precancerous lesions can eliminate the cervical cancer. So we know that global targets of 90, 70, 90. 90% vaccination, 70% screening, and 90% of treating the screen positive women. So this is all the concept all of us have been having it over the years. But how we are going to implement it in the next 20 minutes, I'm just going to touch upon very briefly the strategies for managing the cervical precancer. So what actually, if you broadly divide the cervical intraepithelial lesions are to be more specific, the precancerous lesions of the cervix can be on the ectocervix or on the endocervix. But mostly I'm touching upon the squamous lesions because in one of the seminars of ISCCP, we have discussed about the glandular lesions in detail. So coming to the squamous lesions, it's a precancerous lesions confined to cervical epithelium, the ectocervical epithelium. It's a histological diagnosis made on cervical biopsy. Depending upon the severity of the abnormal changes and degree of loss of maturation and differentiation, it's categorized into different grades. If you see this picture, you will understand the normal epithelium, and we are all very much familiar with the old terminology of CIN 1, 2, and 3. When it is confined, the abnormal epithelium confined to lower one-third, we call it as CIN 1. Two-thirds, it is CIN 2. And if it almost replaces the entire epithelium, we call it as CIN 3. Then coming to the prevalence of CIN, it's overall all types of CIN. In one of the studies, it's quoted as 0.1% to 2.2% in screened population. We usually see more of a CIN1 compared to CIN2 and CIN3. But coming to the change in the terminology, of course, I mentioned earlier CIN 1, 2, 3, but with the last project, that is lower anogenital squamous neoplasia terminology, we have adapted to a two-tiered system. Basically, all the squamous precancerous lesions are divided into low-grade as well as high-grade lesions. So it is mainly to make it a unified histopathological nomenclature, especially the lesions which are HPV associated. So if you use this terminology, we usually consider CIN1 and the HPV changes as low grade, that is LCIL, and CIN2 and CIN3 are going to come under high grade lesions. So CIN2 is, most of us consider it as a gray zone. So in that gray area, there is a role of using immunohistochemistry, the P16 immunohistochemistry. If you see a block positivity on the histology slide of CIN2, that favors more towards a higher grade lesion. If there is no block positivity, this is considered towards a lower grade lesion. So this IHC will help us to decide about our treatment plan for CIN2. So basically CIN1 and CIN3 are very clear cut, but whereas in CIN2 is a dicey situation where facilities are available, we are using immunohistochemistry. So this is briefly the last terminology. Previously, the Richard system CIN1, CIN2, and CIN3. In the last terminology, low-grade squamous dysplasia comes under CIN1. High-grade squamous dysplasia, CIN2 and CIN3 come under high-grade dysplasia. So this concept, one should be very clear about it. And even though we still use the CIN1, 2, and 3, but we need to know the last terminology. So coming to the natural history of CIN, it's a dynamic process. Several studies have addressed the natural history of CIN, especially with an emphasis on regression, persistence, and progression. to in higher grades or to cervical cancer. So majority of low grade lesions are transient. Most of them usually regress, and they usually, especially in younger age women, there is a higher chance of lower grade lesions becoming, there is a chance of these getting regressed. Whereas the chances of progression in with regards to low grade lesions is not as high as what we see in higher grade lesions. So I'm going to show the table, which most of us are familiar with. This is from the IARC manual. So if you see the CINV lesions, 57% regress, persistence is 32%, progression is 11%, and the incidence of invasive cancer is less than 1%. Whereas in CIN2, it is 43, 35, 22, and 1.5%. Whereas in CIN3, the regression rate is 32, persistence is 56, and progression to invasive cancer is about 12%. So this is actually results of a pooled analysis of studies taken from 1950 to 1993, and this paper is presented in 1994. So this very clearly tells us that the CIN1 has got a very higher chance of a regression and very minimal chance of progression into invasive cancer. So this is one of the latest reviews. This also tells us very clearly that the chances of regression are quite higher with regards to CIN1. If you really look into the details of the study, you will understand it's a meta-analysis. They have taken 89 studies totally. In that, they have taken 63 studies on CIN1, 42 on CIN2, and 7 studies on CIN3. So progression of CIN1 to various grades of what I have mentioned earlier, the regression, persistent, and progression are quite significant in the sense you will see more of a regression, less of a progression. On the other hand, when you go for the CIN3 lesions, the regression rates are only 28%, persistence is 67%, and progression is 2%. So the conclusions from this study are most of the CIN1 and CIN2 will regress spontaneously in less than 24 months, especially in young women. Conservative management should be considered, especially in fertile women and with expected high compliance. So the rider is those who are compliant for a follow-up. You can definitely consider conservative managements in lower grade CIN lesions, which may be a challenge in our country. So that's why sometimes we may even consider treating the CIN, which anyway we are going to discuss probably in our panel discussion also. So coming to the treatment of CIN. So there are situations where you have to treat the CIN. You can't leave all the grades of CIN for conservative management. So the indications for treating the CIN are, as I mentioned earlier, non-compliant women with CIN1, persistent low-grade CIN beyond 2 years after a close follow-up, CIN2 and CIN3 lesions, CIN extending into endocervical canal, and associated glandular lesions. So most of the times when you diagnose a glandular lesion, you also need to make sure that they don't have any associated squamous lesions. If both are coexistent, definitely that is an indication for treating the situation. But when you consider that treatment, there are certain factors which will guide you about managing a particular case of a particular woman with a cervical precancer. So age is one important aspect, desire for fertility, the grade of CIN, extent of CIN, persistence of CIN. Pregnancy with CIN is a specialized, it's a challenge area. And then associated gynecological conditions. Some women do come with fibroids, with AUB and many other things. So these are all the factors which will influence you to decide about how you are going to manage a particular woman with a cervical precancer. So for that, you need to have a very detailed counseling with the women, especially when you are going to keep them on a conservative management. So a shared clinical decision is very important when you decide for treating a case of CIN. So when you consider regarding the objective of treating CIN, if you see this picture, you will understand you are seeing a lesion only in one particular area, that is around 12 o'clock on the cervix. But when you consider the treatment, You are not going to just treat this area, you are going to treat the entire transformation zone. So that is the main objective of treating a cervical precancer. Even though you see a visible lesion in one part, entire transformation zone is at risk of developing CIN as it undergoes HPV-induced clonal change. So your treatment is aimed at the entire transformation zone. And whatever treatment you consider excision or ablation, at least minimum depth of 7 mm to clear gland crypt involvement is essential. So 7 mm is the minimum, but of course, based upon the types of the transformation zone and the extent of the lesions, you will even go up to 10 millimeters to 20 millimeters into the endocervical canal. So what are the treatment methods available? So we are all familiar with the ablative as well as the excisional methods. The time-tested ablative methods are cryotherapy, thermal ablation, laser ablation. Coming to the excisional treatments, LEAP or LEDGE, NEDS, that is the needle excision of the transformation zone, straight wire excision of the transformation zone, cold knife cone, and if you are going to deal with the glandular lesions, you will usually use the cylindrical cone and the laser excision. I have not put the hysterectomy here, but it's a very selective situation where you may consider doing hysterectomy, but I have not put here just to make the things very clear. So when do you decide regarding ablation versus excision? So if you have an adequate colposcopy, you can see the entire lesion, the entire transformation zone is visible. There is a good correlation between cytology and histology, no endocervical extension, no glandular involvement, low grade lesions. You will very comfortably consider ablation. So the contrary are the indications for excision. If you have a type 2, type 3 transformation zone where you cannot see the extent of the lesion into the endocervical canal, or if there is no good correlation between the cytology, colposcopy, and histology findings. So all these are the indications, and in addition, persistent CIN after ablation, you will be considering for excisional procedures. Usually for high-grade lesion CIN2 plus, we consider more of an excision rather than ablation unless in a very selective situations in CIN2 cases. So there are lots of guidelines. Our FOXY guidelines are there, ASCCP guidelines there. I'm not going to go in detail about these guidelines. But if you see CIN1 on histology, we have already discussed a lot about conservative management. When you decide about conservative management, definitely you will put them on a close follow-up, and you can call them after 6 months. Most of us call them after 6 months, but ideal recommendation is after 1 year. After a year, you can do the repeat screening. On the other hand, if you decide for treatment, most of the times you go for ablative treatments if the criteria are satisfied. If the criteria are not satisfied for ablation, then you will think of excision. So the similar thing holds good for women who are desirous of pregnancy with CIN1. You have to consider what is the screening test you have done it. Is it ASCUS LCIL in the cytology, or is it other high risk HPV other than 16 and 18, where you can comfortably keep them on a close follow up. And this is the only dicey situation. Even I did the literature search whether you should encourage them to become pregnant while on follow-up, or they need to wait till the CIN1 is cleared and then go for pregnancy. This is a little difficult situation for the clinicians to decide. So definitely on CIN1 with histology, with a low-grade cytology, you can keep them under follow-up and encourage them to become pregnant. CIN2 and 3 on histology, unless the lady is very particular of having fertility preservation. Most of us are aggressive in doing the treatments. That is, again, excisional treatments are preferred over the ablative treatments. So same thing here. We can use IHC here, especially in CIN2. If the IHC in CIN2 is negative, then probably you can put them on a follow-up. And then if the lesion persists, then you will again call them after follow-up and then decide what is to be done, whether you're going to offer the treatment, and after that, whether they're going to plan the pregnancy, you can decide on an individual basis. But on the other hand, if the CIN2 IHC is positive, and other factors are not satisfactory, then you would be definitely going for an excisional treatment. So pregnancy is a special situation. If you have diagnosed CIN in pregnancy, you won't be very aggressive. You can keep them under close follow-up, especially if it is a low-grade lesion. You will follow them up with colposcopy at 6 weeks postpartum. Even if it is a high-grade lesion, unless you are suspecting an invasive cancer, you can repeat the colposcopy at every trimester to rule out invasive disease. And again, you review them after 6 weeks postpartum. Only in invasive cancer, you have to decide about the management based upon the gestational age of the pregnant woman. And these are the ASCCP guidelines. Here also, more or less, the decision tree is similar. You will be following them up more closely. If it is CIN1 with histology, LSIL, here also they take into consideration of the cytology report. Based upon the cytology report, the lady would be decided for a close follow-up versus treatment. So the same thing holds good for ASK-H cytology with a lower grade abnormality. So here the cytology is showing a higher grade, histology is showing a lower grade. So probably you again consider here because they start the screening quite early, they also take age into consideration, and most of us usually start our screening from the age of 30. So less than 25 years, probably you can keep them on a closer follow-up. And if they are more than 25 years, again, you decide depending upon the many aspects. It's not just the histology report alone, the cytology, histology, colposcopy findings, the desire for fertility, everything you would be taken into consideration. Whereas in higher grade lesions, most of us are, even the ASCCP guideline tells you, unless it is CIN2 and the lady is very particular about fertility, you can be more of a definitive treatment that is indicated in women diagnosed with histologic HSIL. So same thing holds good for CIN2 with who are desirous for pregnancy. You need to be putting them on a close follow-up, or if there is no regression, or if there is a worsening, then definitely you need to go for an excisional procedure. So after understanding the various guidelines, basically we can summarize saying that CIN1, if the patient is compliant, you can keep them on a close follow. If the patient is not compliant, or if the cytology and as I said, the correlation is not there. And nowadays with the HPV testing, and most of us with HPV 16 in CIN1, sometimes we do consider doing an ablative procedures. So you can decide about that. Whereas in CIN2 and CIN3, most of the times, if the family is completed, we are trying to go for a definitive treatments. So coming to the cure rates, cryotherapy has got a cure rate of 85 to 94%, thermal ablation 95%, laser ablation 95 to 96, ledge or leap 91 to 98%, CKC 90 to 94%, laser excision 93 to 96%. That means if you have properly selected the woman for treatment, if you have done the proper treatment with the satisfying all the eligibility criteria, so whatever the treatment you choose, the cure rates are more or less similar. So, but the selection of the woman for appropriate treatment causing less or least morbidity is the most important thing, achieving a higher cure rate. So that is what we all need to aim for when we are treating for CIN. So now this is one of the latest IARC evidence summary came out in 2025. So this is all about the thermal ablation. It's cost effective and safe for the treatment of cervical precancer. This study actually was initiated in Zambia in 2017, and more than 3,000 women with cervical precancerous lesions were treated using the thermal ablation. So it is as effective as cryotherapy and large loop excision of the transformation zone for treating cervical precancer. Even some of the women with HIV also, they have offered the treatment. So the key evidence message from this study is thermal ablation is clinically effective and safe for the treatment of eligible cervical precancer. It's in an IARC study, it is the most cost-effective treatment for option for cervical precancer, especially in LMICs because of its Now we have lots of handheld instruments, battery operated instruments, which you can carry very easily into the community, and the procedure can be done. Use of thermal ablation devices is scalable and is endorsed by WHO. Further research is needed into how the microbiome of the cervix and the other factors are influencing the personalized follow-up care, which actually Dr. Aruna Nigam discussed at length in the last webinar. So this summary can be taken, easily available at this link. So it tells us that thermal ablation, when you are considering ablation, probably thermal ablation stands better than cryo. So next, after the treatment, what is the follow-up? So women treated for CIN are at a higher risk of subsequent disease compared to women with general population. So we all know that they need to be followed up at least for the next 20 to 25 years because of the high sensitivity and high negative predictive value. Most of us are using HPV testing as the treatment. It is considered as the test of cure. So for women in general population treated with ablation or loop excision without a histopathology, sometimes we do the loop excision as a see and treat option, but definitely you will be reviewing them with the histopathology report. So if the HPV test results are negative after 1 year, they can be returned to the routine screening interval. That is what the WHO recommends. So you do 1 year follow-up, and if the test is normal, you can put them back onto the regular screening interval of 5 years for a general population. But on the other hand, ACCP recommends a closer follow-up annually, almost for 3 years, then putting them on a regular screening interval. For women living with HIV who are treated similarly with ablation or loop excision, instead of just a 1 year follow-up, you need to call them for 2 consecutive years. And if both the times the HPV test results are negative, then you can put them back onto the regular screening intervals of 3 to 5 years. So that is about the follow-up after treatment of treating CIN. So what about the reproductive outcomes after treatment? Because we are talking a lot about conservative management in younger women and women with desirous of fertility. And even in India also, we are seeing women delaying their pregnancies. So coming to the fertility outcome, local treatments for CIN has no adverse effects. Overall pregnancy rates were higher for treated versus untreated women. This is all the meta-analysis of several studies, mostly a retrospective analysis. The pregnancy rates in women with intention to conceive, it actually was assessed only in 2 studies. So more or less, it gave the similar results of 87.9% versus 94.6%. So coming to the early pregnancy outcomes. This is again, of course, this is a meta-analysis was published in 2015. So similar rates of overall and first trimester miscarriages for treated and untreated women, significantly increased risk of second trimester miscarriages compared with untreated women. But this is only retrospective, as I mentioned, it's a retrospective study, and there were only 8 studies with small numbers, 1.6% versus 0.4%. But based upon that, we cannot very conclusively say that the second trimester miscarriages are more in treated women. There may be various reasons for that also, for slightly increased risk of miscarriages. So probably it is related to the changes in the cervical mucus and other things. And again, it depends upon the type of the treatment what we have given, whether it is an ablation versus excision. And in those retrospective studies of 6, what they have analyzed, they have found slightly higher rate of ectopic pregnancy. So coming to the obstetric outcomes, excisional treatment, we all know it increases the risk of preterm birth, that is less than 37 weeks of gestation, versus no treatment, 14% versus 5%. We all know the reason again, short cervix, and most of us now in obstetrics, very regularly they do the vaginal scans to assess the cervical length and other things, the funneling and other parts, they're being doing it for almost for all the general population. Probably we need to do it for women who had excisional treatment and who conceive. Lurch versus no treatment. Again, it is I think something missed here. You see a little more in ledge treated versus those who are not treated. And again, low birth weight and preterm premature rupture of membranes are also increased after excisional treatments. I think once we understand the pathophysiology of premature rupture, preterm labors, I think one can very easily understand why excisional treatments are a slightly higher risk compared to, especially when you consider doing a type 2 or type 3 excision. One can very easily understand the reason behind it. But as such, the CIN treated women need not be taken out straight away for C-sections unless there is any obstetric indication. So I think I will skip this glandular lesions because as I said, we have discussed it. So the other component is the glandular lesions. Yeah. Okay. So there are lots of, we have discussed the common treatment modalities, what we have been using it. A lot of advancements are happening in the CIN management. Of course, here you see this artificial intelligence, ethical considerations, liquid-based, this is all with regards to the diagnostics. So lots of minimal invasive treatment modalities like ultrasound energy, then this microwave energy, radio frequency, of course, laser also picking up in some places, and even so many things they are trying to evaluate as minimally invasive treatment modalities for CIN, and lots of immunotherapy approaches. Of course, we use imiquimod, not so commonly for the CIN. And likewise, many of the antiviral creams, they are trying to use it to see whether HPV infection can be cleared. And of course, lifestyle, we all know about the smoking, then alcohol. In addition, lots of nutritional interventions are all being used, but none of these are evaluated in any randomized clinical trials. So finally, my take-home message is CIN with low-grade smear abnormalities can be followed up. Persistent CIN for more than 2 years needs treatment. Biomarkers can be used to triage in CIN2. CIN3 needs immediate treatment. Choice between ablation and excision is based on the clinical situation. Glandular abnormalities need definitive treatment. Newer modalities need to be evaluated and RCTs. So thank you very much for your patient hearing, and I wish you all Merry Christmas and Happy New Year 2026. Thank you once again, Dr. Helen, the ISCCP team, for giving me the chance to talk on management of precancerous lesions of cervix.
Pankaj sir, few words. Thank you so much, Leela ma'am. That was wonderful explanation.
Thank
I'm
you.
sure. Yeah. Pankaj sir, would
Thank you, ma'am, because in a short span of time, you have almost covered every aspect of the management of CIN lesions. Because in preventive oncology, diagnosis is not enough. We have to offer the proper treatment and minimal treatment, whatever possible, depending on the type of diseases. So I think it's well covered in all aspects. So any questions, if from the audience, we can take some questions.
Ma'am,
I think we'll
Dr.
take
Lee,
that in chat box. I think we'll take that in
Helen,
chat box.
Okay.
Yes. Yes, ma'am.
Helen, I'm Dr. Lata here.
Yes.
Ma'am,
Hi.
Dr. Leela, I just joined. Sorry for just have one question. We have a lot of the CIN ones who are symptomatic. I mean, they come with persistent white discharge or something like that. In them also, should we avoid treatment for this thing, or can we do an ablation for them?
Yeah, I usually do ablation, Dr. Lata, especially CIN
Yeah.
with symptomatic. And especially if I have done a HPV test and if they're HPV 16 positive, I prefer doing
I'm talking
ablation.
about those who are negative or those who are not willing to test. In those, there's no harm in doing an ablation, right?
Yeah, there is no harm in doing ablation. I think I don't have a reference, but I remember Dr. Padda Basu mentioning once that in, I think in UK or Scotland, they did a retrospective analysis of women who have undergone ablation for benign conditions. And it seems in those women, the precancerous lesions risk was very, very less. So definitely, yes, persistent white discharge with huge ectropions, even colposcopy,
Yes.
everything is normal.
Negative.
We are doing ablation.
We are
Yes.
doing. Yes, ma'am. Thank you, ma'am.
You're welcome.
Thank you. Thank you so much, Leela ma'am, again. And Pankaj sir, thank you for your time. I know this was last minute for everyone, sort of, but without wasting much time, I'll just see if Madam's class can be, we are going to put into practice in terms of treatment. So without much ado, I'll invite my co-moderator, Dr. Raj Lakshmi Mundra. She is additional professor in AIMS Rishikesh. And Dr. Bindya Gupta, thank you so much for your time again. She'll be our subject expert for today. And I'm very proud to introduce our Northeast faculties, Dr. Mamawi. Her full name is given in the panel as Dr. Vanre Mavi. Ma'am, good evening. Welcome to the panel discussion. Dr. Lungan Rongmai and Dr. Amrita. Dr. Amrita Datta is Associate Professor, AIMS Guwahati. Dr. Lungan is a Assistant Professor, AIMS Guwahati. Dr. Dina Pabi is a dynamic youngster from Arunachal Pradesh Medical College, and Dr. Ronita Devi from Imphal Jenims. Welcome all. Madam has really explained nicely how to manage CIN lesion. Treatment aspect is usually considered to avoid disease progression from precancerous to cancerous, while trying to avoid over treatment. However, the last discussion part covers a little aspect of over treatment also, but let's see if our discussion further can bring up more questions which will help clearing confusions regarding management. So Dr. Raj Lakshmi, welcome. I will start sharing our PPT and we can start.
Yeah.
Raj Lakshmi, please.
Hi, good evening, everyone. At the outset, I'd like to thank Team IHCCP and Dr. Helen for giving me this opportunity. So we start with our panel. So we have a panel on ablative versus excisional therapy for CIN, evidence, guidelines, and reproductive implications. Next. Yeah. So ma'am has very beautifully described everything about CIN management. So we will not go into details of this slide. We can move into the next slide. So coming directly to the cases, we have our first case as she's a 39 years female, para 2 life 2 with previous cesarean section, referred from PHC with complaints of discharge per vagina. Per speculum examination, cervix is apparently healthy with frothy discharge. So a pap smear was done for her and it shows as high-grade intraepithelial neoplasia. So the first question is for Dr. Mavavi. So what next investigation would you like to do, ma'am?
Thank you very much. I think for this case, since the pap smear shows high-grade lesions, so I would like to perform a colposcopic examination and triage and do a biopsy if necessary, and then proceed from there.
Yeah, rightly said, because these are the colposcopic findings for her. Would you like to describe?
Okay. Like just by looking, there's nothing seems to be wrong in after NS application, but with green filter also we see no vessels. Then with acetic acid, there's a opaque white aceto-white area which occupies I think the most of the posterior lip, like more than 2 quadrants, and then the margin seems to be irregular. Yes. And
So
then
we have,
on
continue.
lugos, there's a patchy yellow, coloration in the lugos iodine.
So we have done colposcopy for her and the sweat score is 7.
Yes.
So you would like to have a biopsy?
Would like to have a biopsy in this case?
Yeah. So the biopsy shows, so she was pap smear as HSIL and now the biopsy has come out as SIN1.
Okay. So now there's some confusion.
How do you proceed? Yeah.
So the PAPS, the cytology and the colposcopy. So like we can, for this case, depending on like looking at the age of the patient, although she's 39, and most probably I would like to confirm the diagnosis by doing an excisional biopsy. After discussion with the patient and like explaining to her about her choices, or either like if she can come for a close follow-up, she can come also after like 3 months or so, So like, but for me, I think I would like to go for excisional biopsy.
Okay. So you'd like to go for an excisional biopsy. So the next slide, Helen. So if we look at our FOXY guidelines, it says that if the pap smear shows any lesion which is LCL or higher, and you do a colposcopy, the lesion is SIN1, then you can just go for a follow-up of the patient by doing a rescreening after 1 to 2 years with a cytology report. But if we look at the ASCCP guidelines, next slide, please. So if we look at the ASCCP guidelines, so you have very rightly said that you can go for a diagnostic excisional procedure also in this case, considering the discrepancy between the pap smear and the cytology report. Or if
Yes.
you find, if the patient doesn't want to go for excisional biopsy, then you can very well follow up the patient by doing a colposcopy and an HPV-based testing at 1 year for this case. So if you like to go for excisional, that's fine. Now, reports have said that if a CIN1 lesion is preceded by HSIL, cytology is associated with an increased risk for subsequent high-grade lesion. And the risk estimate as per 2019 ASCCP risk-based management guidelines says that the 1 and 5-year risk for developing SIN3 and higher were 3.9 and almost 6.5% respectively. So you can go for excisional, or even if not excisional, you can even follow up the patient at 1 year with colposcopy and an HPV testing. So next slide. So coming to the second case.
Dr. Rajalakshmi, can I just comment on this case?
Yes,
Yeah.
ma'am. Yes,
So,
ma'am. Hi, ma'am.
yeah, very interesting case. One thing is that because, ASCCP doesn't very much believe in ablation. So here we have a T1 transformation zone, and we have a 39-year-old with SIN1 and preceded by HSIL. So even if we are planning for treatment, we can also go for ablation in this case. We just saw if you have a type 1 transformation zone and if the criteria for ablation is met, and that is also what is mentioned in our FOXY guidelines also. And in this case, we can even go for ablation. So we can entirely see the lesion. It's not going inside the endocervix. Otherwise, yeah, we can either observe or treat depending on the patient. Yeah.
Yes, ma'am.
Thank you so much, Dr. Vindhya, for that input. I think with this, we'll move on to the next case, Dr. Rajlakshmi.
So the next case is almost same. The pap smear is now HSIL. But colposcopy, it shows an unsatisfactory colposcopy with type 3 transformation zone. And when a colpo biopsy was done, it shows now CIN3 lesion with HPV 16 and 18 positive. Family of the patient is completed. So how will you proceed for this case, Dr. Lungam? Dr. Lungam?
Thank you, ma'am. Thank you, the organizing committee, for including me as a part of this panel, and thank you for this question. Ma'am, as we can see, the patient is 39 years old with biopsy already proven that she is SIN3, and we know SIN3 has a high risk of progression to invasive cancer. And moreover, the colposcopy examination is already showing type 3 transformation zone where the ablation therapy is not possible. So for this patient, I think we can go for the diagnostic excisional biopsy, ma'am, for the further evaluation.
Yeah. So you have very rightly said that a diagnostic excisional procedure is preferred in this case, considering the age of the patient, SIN3 and type 3 transformation zone. So if we look at the WHO, Helen, next. WHO also recommends that you go ahead with LEAP over cryotherapy in settings where LEAP is available. But ASCCP again prefers excision over, and plus excisional therapy is always preferred in such cases when you have SIN2 and SIN3. If we look at this algorithm, we can see that whether the colposcopy is satisfactory or whether not. In both cases, you have to go for diagnostic excisional therapy in such cases. And after that, you can follow up the patient with an HPV-based testing at 6 months. Next. So, Dr. Lungam, do you think we can go for ablation in such cases?
Ma'am, because her colposcopic examination is already showing that the transformation zone is type 3, where the squamo-columnar junction is not properly visible. This doesn't satisfy the eligibility criteria for ablation therapy. So I think ablation is not recommended here.
Yeah, ablation, because in such cases, considering SIN3, which is a immediate pre-cancer condition for the patient, so we need a diagnostic specimen to confirm, and in such cases, ablation is not at all recommended. Even if we look at the literature, this was a recent meta-analysis. Even if we look at the literature, this was a recent meta-analysis which involved huge number of patients, and it was seen, it compared all the therapies, and it shows that compared with LEDGE, patients treated with ablation methods and high rates of treatment failure in CIN cases. So we see that even the literature also supports that ablation is not recommended in such cases. And then next. Just show all the slides complete. So if we compare all the excisional therapy in such cases, the advantages and disadvantages, I'm not going into detail, but we have already seen that if we do treat the patient with either cold knife conization or laser conization compared to LEDGE, it has got low rates of treatment failure. Plus, if you go for a laser ablation, then thermal artifact was greater with laser compared to LEAP therapy. So LEAP can be a better option in such cases. Bindya ma'am, would you like to add something in this case?
No, this is absolutely perfect. So type 3, this is a correct message that when we have a type 3 transformation zone and the colposcopy is, we are not able to see the ulnar limit, so it's better to go for excisional procedures. And this is the correct message which has been conveyed.
Yeah, Dr. Yeah, I just want to add one thing.
Yes, ma'am.
Yes, regarding the terminology, like we are not using the words satisfactory and unsatisfactory colposcopy. So as long as you see the cervix completely, we call it as an adequate. But even if it is a type 3 transformation zone, we can say that colposcopy is inconclusive or inconclusive. But otherwise,
we can say, ma'am, that colposcopy is adequate with the type 3 transformation
yes,
zone and the lesion upper limit is
yeah,
not
yeah, that is what we are now. That is the terminology we are using it. Yeah.
Yes, ma'am. Yes, ma'am.
Yeah. Okay.
So
Thank you for pointing that out, ma'am. Yeah.
So, Dr. Lungam,
Yes,
do you
ma'am.
think there is any role regarding the margin positivity in such cases, because you are going ahead with diagnostic excisional procedure in such cases?
Yes, ma'am. Since it's already type 3 transformation zone and squamo-columnar junction is not visible, and sometimes lesions which has already exceed into the endocervical canal, for example, large lesion, there is a risk of persistence of there may be risk of incomplete excision, ma'am. So in that case, it is important to know the margin status of the specimen on histopathological examination, and moreover, positive margin may be a significant risk for recurrence or for the persistence of the disease, ma'am. So it is important to know, yes, the margin of the lesion, ma'am.
Yeah, rightly said. So margin is an important predictor for both the disease persistence and recurrence. And it is seen that positive margins are at significantly higher risk for residual or recurrent disease. Like this was a meta-analysis which compared that patients who had negative or uncertain margins compared to patients with positive margins. Those with positive margins, where they had a 5-fold increased risk of any grade post-treatment CIN. So whenever you do an excisional therapy for the patient, it's very important that you look at the margin status of the patient, because with that you can have lots of information regarding the persistence or recurrence in future.
Thank you.
Yeah, also in this case, Dr. Rajlakshmi, I'll just one comment also. If we are doing LEDs in this case, it has to be done by an experienced operator, because we are doing a type 3 excision. So in that case, we do need to take a top hat along with the first loop of LEDs, because here we are dealing with the type 3 transformation zone. So that is why it's very important that it has to be done by an experienced operator. And otherwise, if suppose this is in this scenario, if you can go for a shallow cone or even a needle excision of the transformation zone, because in that case we have one intact specimen, because otherwise in LEDs we'll get two specimens, in which sometimes margins becomes difficult to comment upon. So type 3 excisions, it has to be done by an experienced operator.
Yes, ma'am. That's very important.
And I just wanted to just add that when we are talking about margins, with any procedure involving current and also some artifact definitely is bound to be there. So assessment of the margin might be much, much better with cone excision than compared to LEDs.
Yes, ma'am.
So I think with this, we'll move on to our third case scenario. Dr. Rajlakshmi, please.
So she is a 40 years female. She presents to you with white discharge. As such, there is no significant finding in per speculum and per vaginal examination. So the patient has gone for a primary HPV testing, which comes out to be positive. So Dr. Dina, how will you proceed in such cases? HPV test positive for a 40 years female.
First of all, I'd like to thank the organizing team for this opportunity. And thank you for the question, ma'am. Ma'am, I would like to, since there is HPV positive, so there are 4 modalities for triage, ma'am, according to WHO guideline. So first there is VIA, second we have cytology, third we have colposcopy, and fourth we have first cell genotyping of HPV.
Yeah. So we can proceed with any of the triage testing. So we have done HPV genotyping for the patient. Helen, next slide. So it comes out to be HPV 33 positive. So now we triage the lady with cytology and we find that it's an L-seal. Next. So these are her colposcopy findings. Next, Helen. Next. So show the slide, colpo, sweet score. So now she is HPV test positive. The genotype is 33 positive. You do a cytology, it's an L-seal. So we have also done a colposcopy for the patient and the sweet score is 5. So will you take a biopsy?
Yes, ma'am. We'll take the biopsy from the suspected area, colposcopy guided biopsy. Sweet score is also quite high.
The sweet score is 5, so you take a biopsy. And it
Yes,
comes out as SYN 3. So how will you approach now?
Ma'am, since the biopsy is SYN 3 and her age is 40 years, so we'll go for definite management, which is excisional treatment.
Yeah. Helen, next slide. So can you tell us something about the excision and ablation?
Yes, ma'am.
Like certain advantages and disadvantages in terms of going for ablation or excisional therapy in such cases.
Yes, ma'am. In excisional, we get the tissue, which we can send for histopathological examination, which will we will get a definitive diagnosis from that. And ablation, we don't get the tissue for histopathological examination, so we lose the tissue. So there is no definitive diagnosis in there. But ablation is very safe and it is very easy and it is very simple compared to your excision. So in excision, we have some disadvantages because it is technically difficult. Maybe some surgeons will not be expert in doing proper excision of the suspected area. And also there is a higher risk of some adverse obstetric outcomes like preterm birth or miscarriage.
Yes, you have very rightly pointed, and Bindya ma'am also told us that whenever you have a SYN 3 at diagnosis and biopsy, it's always important that an experienced person does the excisional therapy for the patient. So excision is the preferred modality in such cases for SYN 3, if you look at this. So next slide, Helen. Would you like to follow up the case? You do a excisional therapy for the patient. So how will you proceed further?
Yes, ma'am. Yes, ma'am. According to WHO guideline, we'll do the follow up after 1 year to test for cure to see if there's any residual disease or not, or if the whatever treatment we have given it was successful or not. But according to ASCCP guidelines, the follow up is a bit more frequent compared to our FOXI guideline.
Yeah, but if we follow our FOXI guidelines, so it says that in such cases when the HPV testing is positive and any high risk HPV test comes out to be positive and you triage the patient with cytology and you find that the lesion is ascus or above, higher grade, then you go for an excisional or ablative if possible. If the treatment is eligible for ablation, then you go for excisional or ablative therapy and you keep the patient at follow-up and you review the patient after 1 year. So just one point from Vindhya ma'am. Ma'am, would you like to add something in this case, because she was a scene 3 40 years?
Yeah, so I think the management is right that we have to go for the excisional method of management. And in this, like the follow-up, if we are discussing, the WHO says test of cure at 6 months. Then even ASCCP also tested like a sooner test for SIN3. And Foxy, we said that it is for at 1 year. So what we
1 year,
say
ma'am.
is I do at least between 6 months to 1 year. And since we had an HPV positive earlier, it's better to do an HPV again as a test of cure. And if we again have a persistent HPV, we will take up the patient for colposcopy and then manage it further. So we have to keep the patient a follow-up, and then initially we follow up for at least yearly for three times, and then we have to follow up till 25 years from the point of diagnosis. That's very important, because anytime they can develop they can have a cancer, or they can even develop vein or even vaginal lesions. So we have to keep them under strict follow-up. But yes, for SIN3, I think I will also go for excision rather than ablation. And it's very unlikely, the lesion looks quite mild on colposcopy, but
Yes, ma'am.
surprising.
Yes.
Sometimes we do have low grade lesions, they come as high grade on histology. So that's why. So yes, we always should review our reports. We should always reconsider our findings. So yes, but yes, for SIN3 excision.
Yes, ma'am. Ma'am, you have rightly pointed out that it's important that we review all our pap smear, colposcopy, and histology finding. And if the report stays same, then it is okay. Otherwise, we should keep, at least in such cases, we should call the patient at 6 months and do a point of care test, rather than going for a 1 year testing, because it's a SIN3 lesion.
Yeah.
Yes, ma'am. So moving on to our next case, which is again 39 years female. She presents with postcoital bleeding, and now the pap smear shows ASK-H. So the cervix is relatively okay. It is hyperemic, bleeds on touch, but there is no untoward findings in the pervaginal examination, but pap is abnormal. So Dr. Ronita, how will you proceed in such cases? Dr. Ronita, are you there?
First of all, I'd like to thank you, organizing team ISCCP, and for inviting me here. And thank you, ma'am, for the question. For this patient, I like to do the colposcopy and followed by biopsy. And I would like to do the ECC, endocervical cure test.
Yes, because if it is an ASK-H, then we have to go for colpo-guided biopsy along with ECC. So these are her colposcopy findings. So Helen, next. So now you have done a biopsy for the patient and it comes out as SIN2. So would you like to do any ancillary test in such cases?
If there is the facility for the biomarkers like P16 IC markers, I will go for the P16.
Yeah, if available, you can go for P16 if facilities are available. So now the P16 test has come out to be positive. So it shows that it's a high-grade lesion. So how will you proceed now?
Oh, she is already 39 years and she came with the postcoital bleeding and the colposcopy biopsy showing CIN2 and P16 also positive. So it is most likely the high-grade lesion. So I will go for the excision therapy treatment for the definitive. I want to know the exact histopathology of this patient.
So you want to treat the patient, right?
Yes.
So can you just point out the eligibility criteria for ablative therapy?
For the ablative therapy, the transformation zone should be type 1, and sometimes the shallow transformations are zone type 2. If the probe can reach the scamocolumnar junction, then the lesion should cover the less than 75% of the TZ, and the invasive cancer and any glandular involvement should be ruled out. And patient should not be pregnant, and she is not menstruating.
So yes, you can rightly go for ablative therapy in such cases. Even if the P16 test was not positive, it's not that you have to do it for each and every cases. But if facilities were available, you could go for P16. Otherwise, even our guideline says that if the report is ASK-H, then we go for colposcopy with cervical with biopsy along with an ECC report. And if the lesion is scene 2 and scene 3, you can either go for excision or ablation as see and treat approach. So that was all about this case. So now I hand over to Dr. Helen.
Thank you, Dr. Lakshmi. I'd like to invite our last panelist, the most dynamic of the group, Dr. Amrita. So we are going to discuss about 31 years old Nalli Dravida who's been married for 2 years and wants to conceive. Now she has a problem, heavy menstrual bleeding. Post speculum examination showed bulky irregular cervix. PV's cervix was irregular, uterus normal size. Right fornix thickening was present, but however, left fornix was normal. Pap smear co-testing was done. Pap smear LCIL and HPV testing showing HPV 16 positive. So, what would you like to do next, Dr. Amrita?
Hello, am I audible, ma'am?
Yes, please. Please go ahead, Dr. Amrita.
Oh, okay, ma'am. So in this case, I would like to go for a colposcopy followed by a guided biopsy in this case because we know both the FOXY GCPR guidelines and the ASCCP guidelines generally recommend colposcopy as a starting point for this kind of patients. So I'd like to go for a colposcopy in this case.
Yeah, so yeah, even our ISCCP says HPV positive and such kind of lesion colposcopy is definitely recommended. Now, this was the colposcopy findings. Can you comment on the findings that you see?
Yes, ma'am. Actually, this looks like here it's a type 3 transformation zone, and we can see dense epithelial areas covering the entire cervix. It's quite dense, and we can also see some very fine visible vessels, but which are regular, looks like. And in the fourth picture, there are quite a few distinct yellow spots, particularly in the lower lip. So looks like patient will have a very high sweet score.
His score was reading 7, and we have an ample area to take biopsy from. Biopsy was done, showing CIN3. But as we reviewed from the history, patient is only 31 years old, and now she is desirous of pregnancy. What do you think should be done for her?
Ideally, ma'am, if we go by guidelines, she should have a diagnostic excisional procedure. But had it been CIN2, we could have given her the option of waiting and could have done the proliferation markers or the IHCs. But since it's a CIN3, it's better to go for a leap as a procedure.
Even our GCPR follows that same pattern. I think same format as in non-pregnant females. Other treatment format is not much different as per guidelines. The only thing out here is reproductive aspect that has to be taken into account in this case, right? So in this particular case, whatever, because you were talking about colposcopy and then guided biopsy and excisional treatment, so be it excisional, ablative, any of this procedure, does it impact future pregnancy? Because that will be the main concern.
Yes, ma'am. Actually, ablative procedure is considered to be the safest of all that. Whatever literature we have, the problem is not with ablation, it's more with the procedures of excision like LEAP or CKC. CKCs have been found to have the major associated complications of preterm birth or cervical incompetency more. But then I think we should discuss all the risks and complications of every procedure with the patient and let her take the decision on her own. So at the end of the day, whatever she decides to do.
Thank you, Dr. Amrita. Definitely, because it's all about shared clinical decision making. No? So, parameters when LEAP, the treatment modalities like LEAP conization and laser ablations were compared. Effect on fertility, usually preserved fertility was noted, with ablation, no effect at all. And most of these factors affecting it was associated with stenosis, and overall obstetric risk level was also minimal for ablation compared to low and moderate risk for LEAP and moderate to high for cold knife conization as per the complications discussed. And mode of delivery, usually cesarean section is called for as per the obstetric indications only. None of these treatment had any impact on the mode of delivery pursued for such kind of patients. So having said this, I'd just like to add that whenever a patient is having CIN3, we all know that the risk for progression to cancer is increased. That is why treatment is always recommended. With CIN3, diagnostic excisional procedure is preferred, but if the option is not there, then ablation is still an acceptable alternative. Now, with excisional lesion, the problem was we are disturbing the anatomy. And when we do ablative treatment, theoretically, integrity of cervix is supposed to be better preserved. And in fact, some analysis did find that the adverse obstetric outcome was definitely lower in case of ablative procedures. And adverse reproductive effect, however, in some studies was noted not only with the procedure but with the grade of the lesion itself. Then certain characteristics of the patients like smoking history, infection like bacterial vaginosis, low socioeconomic status, human papillomavirus infections. So I guess in this aspect, a lot more needs to be studied upon. Now, this is a patient who is positive for high-risk HPV, and we all know that HPV is not gender biased, it affects male also. Do you think there is any role of discussing male partner management in such kind of situation? Because patient wants fertility, and we are going to talk about HPV vaccination and treatment aspects which might delay the pregnancy. So in terms of male, any aspects you would like to discuss with the patient?
Many factor infertility can also be explored in detail, but as such, there have been no existing guidelines which have treatment for this male thing. But some isolated studies, maybe they have shown regression of infection patients where barrier contraceptives have been used. So I think that can have a role.
Yeah, because there is no screening for male, number one. And number two, definitely because patient has been diagnosed, some treatment is going to be instituted and some time for follow-up is going to be given to the patient. So we can even discuss the use of condoms because patients, in certain studies, patient who had used condoms, means the male partners who had used condoms, they found that the regression rate was definitely better for those who were using, for the male partners who were using condoms for patients who were diagnosed with any grade of CIN. What about vaccination? We all know it is given for prophylactic.
Ma'am, once infection is established, I don't think vaccination has any role. Maybe we can concentrate on the pre-teen age to give vaccination, but that's difficult.
Yeah, definitely. But you see, because our vaccination that we have is all basis is prophylactic effect only. And so pre-existing HPV infection, it's not going to affect. And however, there were some data which suggested that HPV vaccination is associated with lower rate of CIN recurrence. So this could be in effect due to other high-risk HPV infection. So maybe after explaining the pros and cons, patient can we can talk about vaccination to the patient and explain about the pros and cons of having vaccination at this point of time. Now, the most important thing that we need to know is what about the timing of conception after treatment of CIN?
Ma'am, there is not such guidelines as such that I'm aware of. Maybe we can have the patient come back after 6 weeks once, or maybe after 3 months once, just to see how the cervix has healed. So after that, if healing is complete or on its way, maybe we can ask her to have a trial conception, depending on that.
Yeah. For me, I've been trying to search lots of literature regarding this, and personal experience has been most people who come to me have either conceived or have had babies already, and so I didn't have much patients on whom I can explore this. I did have one, but was lost to follow up. So I would definitely like to have inputs from Dr. Vindhya regarding this particular issue. Dr. Vindhya, please.
Yeah, so thank you, Helen. It was a great case. Three things I would like to highlight in this case. The lesion was very big. So in this case, we should not attempt a LETS. It's better to do a good shallow cone because less than 2 centimeters, we can focus up to 15 millimeters and just take a shallow cone so that we can take the entire lesion. So that is one. And second, in this, like you already mentioned, post CIN treatment vaccination, it is nowadays considered because it helps in preventing the reinfection from other strains, and therefore it does help in recurrence. So we should give the option of, post treatment CIN vaccination to the females. And regarding this, what I believe is at least the first follow up should be done. And if the first follow up is negative, then we can then we can ask the patient, yes, you can just consider. So by the time the first follow up is done, at least 6 to 9 months are over, the cervix is remodeled, the healing takes place completely, and then by the time she conceives, it'll already be 1 year. So that is why at least we should wait till the first follow up. We should give them good contraceptive advice, and after that only we should then advise according to the first follow up that she should do whatever. Because sometimes, if suppose it's a persistent HPV, then we'll again wait for 6 months. If she becomes pregnant, then we'll not be able to evaluate her. So first negative follow up is very important before we tell her to conceive.
Yeah, and I'm sure many of us are very familiar to that kind of scenario where we tell follow up and then patient comes to us pregnant. So it is very important to emphasize on the word follow up again and again, because the scenario is as such in our state. And I think I saw one of our participants asking about difference in guidelines between Western countries and our countries. I just wanted to add this one line, that it's all about tailoring at the end of the day. Guidelines are there to help us pursue which line of action we want to go with regarding that particular patient. So guidelines, we should be up to date regarding the guidelines. But ultimately, when we are discussing treatment, follow-up, it has to be a shared clinical decision with CIN3 lesions like that. Like Madam said, Dr. Vindhya said, definite shallow cone should be taken. So these are aspects where our decision comes into play in relation to the guidelines. So thank you all the panelists, and especially Dr. Vindhya again and again. And I'd like to thank your daughter also for her cooperation. Happy birthday to her.
It's okay.
And I hope it's
But
been
I think, Dr. Helen, you gave a very good message. Guidelines are just to help. We should not be just doing something out of the way, that we are just, that is like in T1, TZ, we are doing large course. So this is not to be done. But you're absolutely right. Guidelines are only there to assist us, and guidelines are to be tailored according to the person. We have to ensure personalized treatment. This is an excellent message which you have given for this entire session. Treatment, we all know, we have been going through it again and again, so with so many panels and so many, but this is something which is very useful, which you have mentioned. And I should first now thank the team Helen. I should say that you have really, really garnered an entirely different perspective of ISCCP today. We had such excellent participation from the Northeast. We are so glad that all the faculty was here. Very nice inputs. My heartiest congratulations to you. Raj Lakshmi, my dear, she is my dear friend and a former SR from our hospital. So nice to see you. Excellent panel which has been conducted, and with great inputs from everyone. So I have heartfelt thanks to all the faculty for for this great panel, and we had such quick, crisp cases with excellent take-home messages. And the last message was the wonderful guidelines only to assist, but yes, always a clinical shared decision and the personalized treatment. Dr. Leela, I should not forget thanking you also.
No problem.
So thank you once again. Dr. Deka, thank you so much for chairing the session. Thank you so much for being there. And so with this, and Dr. Upasna, I think we should ask her also to share some, please share some thoughts of wisdom with us
No,
before
all
we.
it was a wonderful session actually. All the inputs and everything was well taken. All the points were well taken, and as an expert, we also thank you, ma'am, for your expert advice, which the inputs which you had given. And I believe, although we are mostly dealing with invasive part, but it's also important we also get back to the basics, because ultimately you are only strong as how your basics are. So it's very important that we have such kind of sessions very frequent, almost at a regular intervals, and we become a part of it. is very important. That most of the upcoming gynecologists from this region, they attend such kind of training sessions. And Dr. Helen actually is one of the gluing force of the entire Northeast, and it's very difficult to say no to her. So
Yeah.
credit.
Thank you,
Yeah,
Dr.
so she has a
Uparsana.
very
She's the
infectious
backbone.
charm.
Yeah.
And this lady has a very infectious charms, and she's wooed all of us. And so, with this, I think so. Dr. Helen, thank you very much. Dr. Upasana, thank you very much. And it was a wonderful webinar. And we will really like to invite all the people who have signed in today to become ISCCP members. Please do become members. We have two excellent programs which are being done. One is a fellowship in colposcopy and cervical pathology, which is FICCP. We have a very rigorous training with theory lectures online also, and 50 cases are done as practical with the mentor. So please do join us for FICCP. We have the current batch. We've enrolled 75 students are there, and we would encourage people to join the FICCP course. Secondly, we recently have started the vulvovaginal module, in which we have 20 trainees, in which we are doing a comprehensive training on vulva and vaginal diseases, which are also a very upcoming and a very common feature which every gynecologist is dealing with. And another important update is that please do come for ISCCP Con 2026, 28 to 29 March at Adyar, Chennai. So please, we look forward to all your participation. So with this, I sign off today for this webinar and wish you all a very, very happy New Year 2026, and looking forward to another webinar on the 7th of January in the new year. And that is, again, we start with an update on screening guidelines. It will be, the convener is Dr. Shweta Balani for the webinar. So again, till we meet next 7 January, 7 p.m. In the new year. So till then, good night, everyone. Thank you for the very active participation. We had 100 delegates signed in. So thank you, Dr. Helen and Dr. Pasna, for gearing up such a massive crowd today. And it was a really heartening to see the very enthusiastic participation today. Thank you very much, all the faculty and all the delegates who joined in the session.
Yeah, thank you very much, Dr.
Thank
Helen,
you. Good
for all
night.
your
Good night.
efforts. I know, like,
Bye.
how charming she is. Probably my association started
She
with
woos
her. I think,
everybody. That is what.
yeah. Probably if everything goes well, I think she should conduct the next ISCCP conference.
Ma'am, I'll
Absolutely. That's a
definitely
great
try.
idea.
I'll
Now, Helen,
definitely try.
we'll discuss this over.
Yeah, no,
Yes,
I'm
ma'am.
just suggesting. I've been asking her, but because of the political situation, she's not able to do it.
Yes.
Thank you very much, Dr. Bindya, for a wonderful.
Thank you, ma'am, and for answering all the questions in the chat box. We
No,
could see
it's all
there was
right.
there was a second panel which was going on in the chat box
No,
also.
at the
It's all
side.
right.
Yeah.
Yeah.
Thank you. Thank
So
you. Good
thank you
night.
very much. So
Yeah.
good night,
Good
and
night. Yeah.
see you next month, 7 January, 7 p.m. Okay, bye-bye. Happy New Year.
Bye. Thank you.
Bye. Happy New Year in
Thank you.
advance.
Merry Christmas.
Merry Christmas and
Merry
Happy New
Christmas.
Year in
Happy New Year in
advance.
advance. Thank you.
Thank you.